I want to speak about the appendage closure and why the appendage, because that is the site of the formation of, we said up to some months ago, 90% of the thrombus, but it's really 90% or more. I want to show you this interesting paper published by an Italian group in which they found a really interesting aspect for me. That is, I don't know if there is a pointer here, please. Do you have a pointer, please? A pointer, do you have? A pointer? Okay, no problem. It's okay. No problem. Maybe that I show you. Okay, no problem. I show you with this. It's really interesting, this paper, because we said that up to some months ago that 90% of thrombus formed inside the appendage, but we found that more than 90%. Look, in a total of over 1,420 consecutive patients treated by cardioversion, they found that all the most part of only 0.07% were outside of the appendages. This is a very important aspect for our job. Look, only, this is a total number, 8 patients, this is the percentage of the thrombus, only one in the right appendage and one in the cavity. So more than, we are 98% of thrombus inside the appendage. This is an important aspect because that when we speak with the colleagues about the anticoagulation, and they said, yes, but it's really the appendage, the site of the formation. Yes, this is it. Obviously, this is only one paper, but the number of the patients is very, very big. I want to show you about something how, okay, thank you. Okay, thanks. Our setting in the lab when we prepare for the procedure, generally, this is antibiotic prophylaxis. It's like any device implantation. General anesthesia. In our lab, we prefer general anesthesia because I don't like the patient that move. Invasive pressure monitoring. TE, always, because up to now is the gold standard. Sometimes you use intracardiac echo, but only if TE is contraindicated. This is why the gold standard is TE, but also because we have to speak as in correct way. The eyes, the intracardiac echo is expensive, and if we pay a lot, too much for one procedure, it's not possible to have a lot of procedure. It's not possible to treat all the patients. Something about the transeptal approach. We published some years ago a paper. This is not only 6 patients, but interesting, in collaboration with the IC of our hospital. We tried the needle, the RF transeptal needle. There is the possibility to have the transeptal approach with a needle with the radio frequency. It's a dedicated catheter that is really expensive, but we had this, this needle for free, and we had some experience. It's important because the transeptal aspect, the transeptal puncture is a crucial point of this procedure. So we suggest, if we have to do an appendage closure implantation, try in this way. PVI ablation, best inferior part, mitral clip, obviously on superior part because the introducers needs to go from up to down. This is why when we have to implant a device for the appendage, we have to show the best, the coaxial way, because otherwise it's not possible. This is the best. Okay. Oh, sorry. Oh, sorry. I apologize. Okay. So this is the best. The transeptal is important. Try to be coaxial with the major axis of the appendage. Okay, perfect. Sorry. Some on the WATCHMAN, that is the device that we have to implant today. This is the WATCHMAN FLX. It's very, it's amazing. And this is the old one. We can see in comparison both. As first, on the distal part, the old one is open and the new one is closed. It is important because there are not this kind of anchors on the tip in the new one, and it's possible to go ahead inside the appendage. Inside the appendage, really safe. With the previous one was not so safe to go ahead, and the technique of implant was different. But now we can go ahead directly moving inside the appendage. And then there are 2 files of rows, look, and in the old one only 1 file of rows of 10, and now with the new one we have 18, and it's very smart. And then it's the device is covered by maybe 80% of the device. So it's also, if you have a procedure that is not perfect and the device is not completely inside, that is not the best, but sometimes maybe happens or moved after the procedure, up to now I don't see any kind, but there is no problem because the device is closed. And then everything changed also for the shape, but this is a really important aspect of the procedure. An overview also here. Look, it is closed here, and then it's very we have the anchors, perfect device. Okay, something on the device still. This is a marker band. It's important that is radio pack, and it's important to see when you have the procedure, and it's important to because here you have to take and to see it, because here you have the implant shoulder, and when you go ahead with the device, this ball needed to be twice of all the sheet. Something still on the approach. Generally, you are in the appendage at the beginning, at the initial part of the appendage, and this is, you move a little bit ahead. When you have this, avoid distal motion, still avoid distal motion, but now, look, it's like a American football ball here. When you have this kind of shape, you can move. You can move, and you can also, if you are in a proximal part of the appendage, you can move safely inside the appendage, also in the distal part, because it's really flex, as like the name of the device. Obviously, when you are with this shape, try don't go back. Don't go back because the anchors are here and not here, and maybe, but in theory, up to now, don't happen in my personal experience. If you go back, you can create some damages to the appendage, but more theoretical like that practically. There are different approaches for the implantation. This is the unsheath, the advanced, but I prefer the combination of both methods. When you have the unsheath, as like the previous, you go inside, target this, go inside and deploy it. But I go quickly because, okay, this is a traditional look. The unsheath, you are on inside the appendage and unsheath. Okay, perfect. Okay. This is the old way you can work in this, but it's possible also to advance. In this case, you have always target this point that is the ostium, and then advance. And advance like this. But I will show you. Look. And cheat a little bit, and then move, 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 move. Okay. Okay, perfect. It's safe, really safe. You can move in this way inside the appendage, and does nothing happens. And at the end, it's really interesting because that you can have any kind of shapes, because at the end of the procedure, the shape of the device is the shape of the appendage. This is interesting because there is not, this is a kind of tablet, but you can have every possibility. That you have the appendage, and then the device has the shape of the appendage of the device that used, but the appendage that you closed. Some clinical cases. This a patient of 61 years old, male. These are this factor: hypertension, current smoker, histories of COPD, alcohol and drug abuse. He's a funny patient. Previously treated with peptic ulcer, chronic kidney disease, and hospitalization for congestive heart failure, diagnosis of HCV-related hepatitis cirrhosis. This is, sorry. Episode of atrial fibrillation, thrombocytopenia, ASBED score 5. So this is it. Okay. Look, it's very, very difficult. With the previous device, a kind of this kind of appendage is really difficult to close. But look with the echo. But we can go easily. The device that we used in this case was the 24. It's very, very. Look at the shape, and look after the shape how it moves. Okay, perfect. Okay, and then this is the final position if we go to the moon. With another device, it's really difficult to close this small appendage. And then there's a follow-up. This only cardioaspirin because high risk of bleeding in this patient, and then this is our strategy. If we have a patient with high bleeding risk, we don't have the traditional approach with the dual antiplatelet for 3 months, but we chose for only antiplatelet therapy for 3 or 4 months, and then we stop if it's necessary. Because sometimes we have patients as like this with high risk of bleeding, so if it's necessary, it's not mandatory in our experience to have this kind of traditional approach. We can adapt, we have a tailored approach to any patient. And another patient, this is a male, 84 years old. These are risk factor, ischemia, and then also this is TIA, implante loop recorder for presyncope, cerebral CT can show ischemic lesions. Also this is with it's a look, pettinato muscle, is a close. When you have this kind of morphology, it's really, really difficult to close the appendage with a traditional device. But with this, also in this case, 24, look, and then tag test. The tag test is like the previous device. So there is a cable, unfortunately, but it's not. Okay, look at the tag test. Perfect. And then this is the final position. Perfect, completely closed. Also this. Okay, completely closed. Look how it's interesting. Obviously, the contrast is now is okay because it is a filter. It's not a plug, but it's completely closed. Look here, the ridge, perfectly closed. Also, this appendage, and T and at the final position, T is perfect. It's closed. Just a question. When I go to the congresses and I show this slide, some person said, yes, but it is not closed here. Here is not necessary to close because this is not, this atrium is not appendage. This is why, but this is the approach of the competitor. If you have a devices like the main competitor, you have to close also this, but it's not necessary because this is atrium and it's not mandatory, it's not necessary to close this. So this, for me, is a perfect procedure. And also the patient is perfect up to now. This is the therapy. In this case, a standard approach, cardioaspirin completed for 3 months, and then everything is normal in this patient because he is a standard patient with a not high risk bleeding case. This is just to show you what changed in the approach. This is with the previous device in theory, but inside with this device is really difficult and really dangerous. And then with the new device, you can move differently. Look, this is the Markel band, remember, when we implant in the lab. And then we go there on the end of the appendage, and we can move. And then when we are at the end of the appendage, we complete the sheet. You can have this. You can have, I'll show you, this is safe, not dangerous. This is it with the device. You can, it's not mandatory to go really inside. You can have a neutral orientation of the sheet, mid to anterior stick aim of the shoulder here. Oh, perfect. Another case, this is a female, hypertension, atrial fibrillation in therapy with warfarin. This is a medical history. This is aphasia. And the CT scan show large sylvian hematoma secondary to arteriovenous malformation. And then we switched to low heparin, regular evolution of hematoma, residual aphasia, but high risk of bleeding in this case, indication for us to appendage closure. And, but this is a patient, T presence of thrombus, persistent of thrombus despite the heparin, and then we, on March of the previous year, we scheduled this patient with the Claret system for the protection because of the presence of the thrombus. This is in the lab, look, so, thrombus inside, so high-risk patient. This is the angiography. This is the angiography. Generally, I don't use the injector. I'm AP, I don't use the injector because for a standard procedure it's not mandatory, but if I have to use the pigtail for the angiography, I ask for the injector because it's more easy and it's possible to have a best visualization of the patient and the aortic. And then this is the device that is placed in the correct position. Look from here and here. This is the transeptal puncture with the TE. Look, have you seen you saw the smoke inside? Okay. And then the same of the previous case, and you can see. Look at the device, is completely inside. One shot to avoid. Look, it's possible to go inside. You can push, obviously, with the head, the hands and the head, but it's possible to push. It's a very, very interesting approach. This is to minimize the possibility of the embolization, also if we have the device of protection. But it's possible to do, and remember these images because it's really interesting. I'll show you another time. Look. You can push. Okay, perfect. You can push and complete with the sheet. And then this is the procedure, the device at the end of the procedure. And then we published this because this is the first publication on the FLX, and was interested to publish with this we name no touch technique. This is the idea, a name, just to give something of new. And then this is what we found in the filter, some images. There's before the protection system, everything, but this 3D looks how it's nice in 3D. It's completely close to the appendage. And then interesting, this is what we found inside the filter at the end of the procedure when we remove the hole. The patient is fine, and is perfect, so it's okay. Another patient, a patient 2 years old, cardioembolic stroke with, treated with thrombolysis. Diagnosis AFib treated with antitherapy therapy. Look, this is a very difficult to treat patient because there is a mutation of 5 factor of Leiden, high risk of thrombosis, and started with the NOAC, recurrence of AFib, of TA, thrombosis resolved in this case, fortunately, with heparin, but this is a high-risk patient for recurrences of thrombosis. This is, sorry, I don't have the tape. I don't know why there is a problem with the, okay. But this is the device. But after was symptomatic, still symptomatic for recurrences of AFib, also in amiodarone and we scheduled after 3 months 1 AFib ablation. This is the map. Okay, no appendage, obviously. This is the fusion. Look at the fusion here. You can see this is the device, the mapping catheter, the other catheter. You can have also the fusion of the device, and the patient unfortunately is no recurrences of AFib. Now continue therapy with the NOAC and the cardioaspirin for high risk of thrombosis for the problem. Something about the possibility to treat to treat this patient, generally these patients with the thrombus is possible to do. We published, I showed before, but there is also another paper. This is a paper published by Tarantini, first name, but there are some colleagues from Spain, and we showed in this case series the possibility to close the appendage also if there is the thrombus inside, better with the protection cerebral system. Just before to end, this is an Italian consensus published in the European Heart Journal, but we are trying to treat this kind of patient. Every frail patients, dialysis patients, in patients with dialysis, the patients in dialysis are the best for this treatment, for my personal experience, because there is not a possibility to use the new anticoagulation therapy. The warfarin is not good. Maybe there is a problem of calciphylaxis, and they published something on this, but we published up to now only the initial experience on 50 patients, and we hope to publish also the follow-up on 1 year, and this I can say now that is the perfect follow-up of these patients. But I want to show you this kind of patients. There are patients that are not included in guidelines, and are the patients in which the therapy with the anticoagulation is not effective. There is not a really contraindication. There is the ineffectiveness of the patient, of the therapy. So if in our labs, in EP lab, we see a lot of patients they are in therapy with the warfarin before or a new anticoagulation now, and there is a thrombus inside. This is another indication for me. We are trying to publish something. I hope to publish as soon as possible, because then there is another indication, no contraindication, indication for completed therapy. After this, we don't stop the therapy, we continue for at least of a year, and then we see how is the best for the patients. Thank you for your attention.